We'll now turn our attention to the pelvis and perineum, and there are only a few topics for us to cover that are of high yield. We'll take a quick look at the female pelvis, and then look at a few issues relating to the male pelvis and perineum. And then finally, we will review what we have studied in the abdomen and pelvis using radiology to do that, primarily CT scans. In the female pelvis, the first and perhaps most important thing I want for us to go over is the peritoneal relationships in the floor of the female pelvis. So in this sagittal view, the posterior side is to the right, the anterior side is to the left. Here's the rectum, and we can see the parietal peritoneum coming down on the anterior wall of the rectum. It comes all the way down to the floor of the pelvis and then reflects up onto the uterus, goes around the fundus of the uterus, and then reflects onto the dome of the bladder, and then onto the anterior wall, and then up the anterior abdominal wall. As a result of those reflections, we develop two peritoneal recesses. One here between the rectum and the uterus, called the recto-uterine pouch, or the pouch of Douglas, and that's going to be a very important region for us clinically. And then the other is this one here between the uterus and the bladder, called the vesico-uterine pouch, which actually is not of any major importance at all, so we're not going to spend any time on that. Now, what makes the recto-uterine pouch important are really two anatomical points that are in a way similar to what we said earlier about the importance of the costodiaphragmatic recess in the pleural cavity. And if you recall, we said that the costodiaphragmatic recess is the lowest part of the pleural cavity, and therefore fluid in the pleural cavity by gravity will track down into that recess, and that's where we would detect it. Well, similarly, the recto-uterine pouch is the lowest part of the peritoneal cavity, so fluid in the peritoneal cavity will track down to the bottom by gravity, and it will accumulate in the recto-uterine pouch. So that's where you would expect to find it. As an example, if you recall when we talked about the peritoneal relationships to the stomach, we said that if there was an anterior perforation of the stomach wall, that the fluid would be able to track down through the peritoneal cavity all the way to the floor. And so what that's saying is that that gastric content would in fact track all the way down to here. The other thing that was important about the costodiaphragmatic recess is that not only was fluid accumulated there, but you were able to get to the fluid in that location because you could get there without risk to the lungs. Well, we can say something similar to that here. Here we can say that the fluid is accumulating in the recto-uterine pouch and you can get at it. Now, what we mean by get at it is something a little bit different here. What we need to do for a moment is turn our attention to the vaginal canal. When we look at the vagina, we see that projecting into the sort of anterosuperior wall of the vagina is the cervix. And because the cervix projects into the vagina, it creates these recesses that surround the cervix. The recess is called the fornix, and it encircles the cervix. And the different regions of the fornix are given different names: posterior fornix, anterior fornix, lateral fornices. But in particular, we see here is the posterior fornix. In other words, the part of the vaginal canal above the cervix is this recess right here called the posterior fornix. And we can see that the wall of the posterior fornix is very, very close to the wall of the recto-uterine pouch. It's only a very thin fibrous layer separating those two spaces. So that means that with an examining finger and examining digits in the posterior fornix, when you push up on the wall of the posterior fornix, you're in fact pushing up on the floor of the recto-uterine pouch, so that if there is fluid in the recto-uterine pouch, you'll be able to feel it through the wall of the posterior fornix. It also means that you can introduce an instrument into the posterior fornix by penetrating that wall of course using aseptic technique, and you can then withdraw fluid from the peritoneal cavity, or you can introduce instruments, fiber optic instruments, and do endoscopic procedures in the pelvic portion of the peritoneal cavity in the female by going through the posterior fornix. It's that very same close relationship between the posterior fornix and the rectouterine pouch which has led to considerable amount of morbidity and mortality in women as a result of untrained individuals attempting to terminate pregnancies without being familiar with the normal anatomy of the region. If one passes an instrument up the vaginal canal, intending to pass that instrument through the cervical canal to get into the uterus, presumably for the purpose of terminating a pregnancy, if one doesn't know that the cervical canal makes a right angle turn with the vaginal canal, and if you pass that instrument straight up the vaginal canal, you'll go right past the cervix, you'll end up in the posterior fornix, and then with just a little bit of pressure, you're going to penetrate the wall of the posterior fornix and end up in the peritoneal cavity of the rectouterine pouch. And since it may well be that that individual who has done that also doesn't know aseptic technique, you may very well have now introduced infection into the peritoneal cavity. So it's that close relationship that has led to a great deal of great many problems for women who are having those procedures done by people who are untrained to do them. Now, when we look at the rectouterine pouch, but from behind, if we position ourselves back here behind the uterus in the rectouterine pouch, we're now looking at the back wall of the uterus. Behind us is going to be the rectum. And in front of us is not only the uterus, but we see the broad ligament with the uterine tubes. And attached to the back surface of the broad ligament is the ovary. So that's the ovary suspended from the posterior wall of the broad ligament. If you recall, we talked about the fact that when the ovary ovulates, what's being ovulated, that secondary oocyte that's being ovulated, gets released into the peritoneal cavity. And we talked about the possibility that it may not get pulled out of the peritoneal cavity into the uterine tubes. And we talked about the possibility of fertilization occurring in the peritoneal cavity, development beginning in the peritoneal cavity, and 6 days later, implantation occurring in the peritoneal cavity. And so now we can see, because of the fact that the ovary is on the back wall of the broad ligament, meaning that it's suspended in the rectouterine pouch, that this ectopic abdominal pregnancy, the most common site for such an implantation to occur, will be in the rectouterine pouch because the ovary is suspended in the rectouterine pouch. And the last important anatomical relationship that has a great deal of clinical relevance that can be seen on this slide is right here, where we see the uterine artery approaching the cervix from the lateral pelvic wall. So the lateral pelvic wall is over here. The uterine artery comes from lateral wall toward the midline to get to the cervix and then travels up along the uterus. At the same time, we see the ureter, which is coming down the posterior abdominal wall, crossing the floor of the uterus, and then heading up to get to the bladder, which is on the other side of the broad ligament. And so we see that the uterine artery is crossing from lateral to medial as the ureter is crossing from posterior to anterior. So those two structures cross one another pretty much at a right angle, with the uterine artery passing over the top of the ureter, or the ureter passing under the uterine artery, either way. And the mnemonic that's sometimes used to remember that is that the water, meaning the urine in the ureter, passes under the bridge, with the uterine artery being the bridge. So the ureter passes under the uterine artery. And since ligation of the uterine artery at this site and obviously bilaterally, is an important step surgically when doing a hysterectomy, one must take care to be sure that the ureter is protected when ligating the uterine artery, because we certainly don't want the ureter to get caught in the ligature or to be damaged in the process of ligating the uterine artery. So that's what we'll say about the female pelvis. Looking at the male pelvis and perineum, there are a couple of different issues for us to discuss. In the male pelvis, we see the bladder, and the bladder, of course, empties into the urethra. And then we see the urethra continuing on down. The urethra initially passes through the prostate, so that portion is called the prostatic urethra. Then the urethra passes through the urogenital diaphragm, so that short segment is called the membranous urethra. And then the urethra enters the bulb of the penis and continues out along the corpus spongiosum of the penis. So that longest portion of the urethra in the male is called the spongy urethra, the part that's in the bulb and corpus spongiosum of the penis. So the three parts of the male urethra are the prostatic urethra, the membranous urethra, and the spongy urethra. Now, the urine that's in the bladder is going to be expelled from the bladder through the urethra to be voided. The muscle that's forming the wall of the bladder is referred to as the detrusor muscle. So almost the entire bladder wall, the smooth muscle of the bladder wall, is referred to as the detrusor muscle. Now, this, of course, is smooth muscle, and as such, it's innervated autonomically. And it's innervated by parasympathetics, specifically sacral parasympathetics, so those are called the pelvic splanchnics. So that's what innervates the smooth muscle of most of the wall of the bladder. And that smooth muscle, this detrusor muscle, is arranged in the bladder wall in basically a crisscross or meshwork arrangement, so that when this muscle contracts, it squeezes down on the lumen of the bladder, thereby squeezing the urine out of the bladder. Now, on the other hand, when we get to the neck of the bladder, just as the bladder is going to empty into the prostatic urethra, the neck of the bladder, there the muscle, it's still smooth muscle, but the muscle is arranged in a different geometry. It's arranged in a circular fashion so that it is encircling the orifice leading out of the bladder, encircling the entrance into the urethra. So that smooth muscle, instead of calling that the detrusor muscle like all the rest of the bladder, we call that the internal urethral sphincter, the internal sphincter. So it's also smooth muscle, but because of its different geometric arrangement, it has a different function. In this case, the function is that when it contracts, it will close the opening into the urethra, thereby retaining urine in the bladder. So the detrusor muscle, when it contracts, expels urine from the bladder. The internal urethral sphincter, when it contracts, retains urine in the bladder. Because it's smooth muscle, it's also autonomically innervated, but not a surprise that since it has a function that is opposite from the detrusor muscle, its innervation is the opposite. So instead of being innervated by parasympathetics like the detrusor is, it's innervated by sympathetics, specifically the lumbar sympathetics. We'll come back to that discussion in just a moment. The urethra then passes through the prostate and then passes through the urogenital diaphragm. Now, the urogenital diaphragm itself is mostly made up of skeletal muscle. And the name of that skeletal muscle is the sphincter urethrae muscle, as indicated here, and often it's simply referred to as the external urethral sphincter, So that's skeletal muscle, and since it's skeletal muscle, it is somatically innervated, not autonomically innervated, and it's innervated by branches of the pudendal nerve, as indicated here. So that leads us to a fairly obvious question, which is, why are there two sphincters? Why do we have both an internal sphincter and an external sphincter? Logic would say that either one of those sphincters by itself would be sufficient to serve the function. And that would be true if the urethra had only one function. But in the male, the urethra serves two functions. One is to carry urine from the bladder, but of course the other is to carry seminal fluid from the seminal vesicles, ductus deferens, and prostate. So let's see how that happens. What we see here is the ductus deferens and the seminal vesicle coming together. The ductus deferens and the ductus seminal vesicle comes together to form the ejaculatory duct. The ejaculatory duct passes through the prostate to reach the urethra, the prostatic portion of the urethra. And so that provides much of the volume of the ejaculate. Probably a little over half of the volume of the ejaculate is coming from the seminal vesicles and with a little bit from the ductus deferens. And then adding to that, we have the prostate itself, which has multiple ducts that empty into the prostatic urethra. So between the fluid coming from the seminal vesicle and the fluid coming from the prostate, that comprises the great majority of the seminal fluid. And the important point here is that all of that fluid is coming into the urethra in the prostatic portion of the urethra, which means it's the part of the urethra between the internal sphincter and the external sphincter. And so that leads us to an understanding of why we have two sphincters. When we want to use the urethra to carry urine from the bladder, then both sphincters will be open. But when we use the urethra to carry seminal fluid, then we want the internal sphincter to be closed with the external sphincter open. The fact that the internal sphincter is closed means that when this fluid from the prostate and seminal vesicles goes into the urethra, it cannot go retrograde up into the bladder. It can only go orthograde out into the membranous and then spongy urethra. So the closure of the internal sphincter by way of its sympathetic innervation is an important component of the ejaculatory reflex. Now, when we talk about ejaculatory reflexes, it's commonly said that ejaculation is under sympathetic control. It's a sympathetic response. What that fundamentally means is that during ejaculation, all of the smooth muscle contraction that occurs during ejaculation is being stimulated by sympathetics. So what that means is the smooth muscle of the seminal vesicle is contracting to squeeze fluid out of the seminal vesicle. The smooth muscle of the ductus deferens is contracting to carry sperm through to transmit sperm through the ductus deferens. The smooth muscle of the ejaculatory duct is contracting. The smooth muscle of the prostate is contracting. All of these things are happening for the purpose of propelling fluid into the urethra, and then the smooth muscle of the urethra is contracting, again to help propel fluid. And at the same time, the smooth muscle of the internal sphincter, which is also sympathetically innervated, is contracting, thereby preventing retrograde flow of the ejaculate up into the bladder. So that explains why we have two sphincters. Now, another important anatomical feature about the male urethra can actually be better seen on this next slide, which is a frontal view. Here again, there's the neck of the bladder. The internal sphincter would be here and here. There's the prostatic urethra passing through the prostate. We can see the openings of the ejaculatory ducts there and there. And then we see the urogenital diaphragm here with the membranous urethra passing through it. And then this is the bulb of the penis with the spongy urethra within the bulb of the penis, and that will continue on out as the corpus spongiosum. What I want to point out on this slide is that the membranous urethra is passing through the urogenital diaphragm, and the urogenital diaphragm is an extremely stable structure. It is tightly adherent to the bony pelvis. We can see the attachment of the UG diaphragm to the bony pelvis here and there. So the urogenital diaphragm is a very rigid, sturdy platform, meaning that the membranous portion of the urethra is really quite immobile. In contrast, when we look at the bulb of the penis here, we see that the bulb of the penis has no bony attachment to anything. The bulb of the penis is simply attached to the undersurface of the UG diaphragm by fibrous connective tissue. And so that means that if a shearing force is applied in the region of the pelvis or the floor of the pelvis, that shearing force can shear the bulb of the penis across the bottom of the urogenital diaphragm, right there. And at this junction between the membranous urethra and the spongy urethra, where we're going from the most stable part of the urethra to the least stable part of the urethra, that's where the urethra can tear. And if the urethra tears at that point, that means that urine that is in the urethra can escape from the urethra and flow into this space here surrounding the bulb. That space is called the superficial perineal space. So urine from the urethra, with a rupture of the urethra in the perineum, urine can escape from the urethra into the superficial perineal space. If we go back to the previous diagram for a moment, we can see, here's that superficial perineal space where urine is flowing into. We can see that that superficial perineal space is directly continuous with the scrotum and is directly continuous along the shaft of the penis and is directly continuous onto the anterior abdominal wall. So that urine that escapes from the urethra here can flow into the superficial perineal space, into the scrotum, along the shaft of the penis, and up the anterior abdominal wall. That's called extravasation of urine. And when it gets into the anterior abdominal wall, it will be in the same plane as the plane of the scrotum, as the plane of the superficial perineal space, which means the plane between layers 2 and 3 from our schema of looking at the layers of the abdominal wall. In other words, between the superficial fascia and the external oblique layer. So extravasated urine from a rupture of the urethra in the perineum, in the superficial perineal space of the perineum, can extravasate onto the anterior abdominal wall, and when it does so, it will be in the plane between scalpus fascia and the external oblique layer, which is the same plane as the superficial perineal space and the same plane as the cavity of the scrotum. So that's all we'll say about that.